Okay, hi, good afternoon. I think we're a small group, but very high quality. So I'm glad I brought so many residents to this meeting because it's a shame because this is an excellent session, and I think the quality of the talks and certainly of the speakers are absolutely outstanding. And I know that everybody's gone to a big effort to be here. So. I think we'll get started. I'm Liane Feldman from Montreal and Theodore Grantroff from the University of Toronto. And this is a session that about the use of simulation in surgical training. I think we have a really excellent. You can put the first slide, please. Just to review what we're covering today, I think this will provide. I think this meeting has really set the scene for this session. We heard from Dr. Bell yesterday about the significant issues in our traditional training model, and his feeling that surgical simulation, robust surgical simulation, is a huge part of the solution to this challenge. We heard from Dr. Dorado today about the incredible innovations in VR simulations. And at this point, I think this session will allow us to really summarize where we are with evidence for surgical simulation, but even then going beyond that to really how we challenges in integrating this into curricula and how to use this effectively in training, and the next level. So integrating this in the real world with team training, with people interfacing with simulation, and what are the obstacles about the big picture of where we are with this now. So I have the opportunity to begin the session with the first talk, just to situate everybody about where we are with the evidence. What's the level of evidence for the use of simulation for skills training and for procedural training in laparoscopy, and just to bring everybody up to speed with where we are with that now, to set the scene for the rest of the session. These are disclosures. So when we discuss simulation for teaching, the fundamental assumption that we make, obviously, is that skills that we acquire through in the simulated environment will transfer to the clinical environment, to the clinical setting. When we discuss the use of simulation for assessment, we make a similar assumption that performance in the simulation will correlate with performance in the clinical setting. And we will have a discussion about assessment later. But in this talk, I'm really focusing on simulation in the teaching environment and as a teaching tool. So what I'd like to do in the next few minutes is basically bring to you what the status of the literature is now. And so I did a literature review asking the question, does simulation training, either through box trainer, for virtual reality, improve clinical operative performance in humans? There's lots of studies with different models, but that's what I wanted to stick to. And just so you'd have that knowledge about that, the evidence that's available now. The evidence for that I identified was, and I just stuck to randomized trials, was nine randomized trials. 6 of them focus on part task training, meaning not entire procedures, but either dexterity or psychomotor skills, so the fundamental skills that underlie our procedural skills. And 6 of them were investigating those interventions, and 3 of them were investigating whole procedural interventions. And there are also a variety of systematic reviews, a number of systematic reviews. And I'd like to start with one of those just because it reviewed very systematically the literature up to December 2006. This is a systematic review from the Australasian College in Adelaide, where they have a fantastic technology assessment group led by Guy Maddern. And this is from the Annals of Surgery, and reviewing the literature up to December 2006. And they did review, their outcome was performance of laparoscopic cholecystectomy and also of endoscopy, but I'll leave the endoscopy part and we'll just look at the trials they had for looking at the evidence for transfer from simulation to laparoscopic cholecystectomy. And one of the things I think that comes up when you review this literature is the big, you know, you'll recognize most of the authors of these papers, and I think it underlines the significant contribution that people at this meeting, in fact, have made to this body of literature. It becomes obvious once you review it in a systematic way. But at that point, there were 3 trials in this systematic review with looking at transfer to laparoscopic cholecystectomy. So all of these trials involve surgical trainees, usually novice surgical trainees, enrolled between 16 and 22 patients. 1 was in a physical box trainer. 2 were using the MIST VR, which is a virtual reality simulator with low fidelity, so it's really psychomotor tasks. It's not procedural. And the evaluations were these were evaluations of in laparoscopic cholecystectomy. How is performance evaluated is another big issue in the design of these kinds of studies. 2 were using global rating scales, and 1 used error analysis, and all 3 showed benefits to in the group with simulation training, either with improvements in global performance or with significantly fewer errors that were made in the performance of the procedure. The conclusion from this systematic review, conclusion from their review at that time was that the skills acquired by simulation-based training seemed transferable to the operative setting. They did have concerns about the evidence base with the studies with variable quality and variable methodological issues. And they requested more studies are required. Usually everybody ends that way, but they did that too. So since then, there have been more studies, and so I'd like to bring you up to date with that. This is one study that I know very well, so I'll take you through this study in a little more detail, but I think and it gives you an idea about what the design is like of many of these studies. And in this study, we looked at whether FLS training improves performance in the operating room. And similar to those other studies, we randomized junior level residents, PGY1 and 2. We evaluated their performance in the FLS simulator and in the operating room using a global rating scale that was developed for this purpose. Actually, that's where it came from, was as an outcome for this study. And people were randomized either to a control group that went on with their regular on-the-job training, as we call residency, and a training group which had their regular on-the-job training with the addition of FLS training to proficiency, and I'll describe the curriculum. And then they were assessed again by assessors that didn't know their treatment allocation, as it were, and they were assessed again in the operating room and in the simulator as well. So the assessment tool that we use, a global operative assessment of laparoscopic skills, it assesses 5 domains, gives you a total score, and of course it's called goals because we like hockey, and this is CAGS, or Canadian Association of General Surgeons, and so we had to have something about hockey in there. But that's all the hockey. So what was the curriculum? The curriculum was the FLS curriculum you can get through the website. And this required, it's quite a high level of proficiency, much higher than required just to simply pass FLS. The proficiency goal took this group of people over 7 hours to achieve this goal. The range was 5 to 12 hours, distributed over 9 sessions. Most of it was independent practice. About 1/3 was proctored. And of course, in the simulator, people improved their performance. That's not a surprise. And what happened in the operating room? At baseline, the performance was similar. There was no difference in the groups, and they were around an average of about 12, which is where we previously had seen PGY 1s and 2s, and they were assessed doing, the task they were assessed on was the excision of the gallbladder from the liver bed. And the two groups, the control group with their on-the-job training, the on-the-job training group improved their performance significantly by 15%. It was over a period of about 3 months' time, so that's good. So it works a little bit. The on-the-job training plus FLS simulator training improved their performance by 54%, which we believe is a clinically relevant difference because, as I said, this group was still at about 13, which is still in the range for PGY 1-2, whereas the FLS trained became at the level, average level where we'd previously seen PGY 3-4. So this shows evidence for training a pre-trained novice. The pre-trained novice comes to the operating room already having the fundamental skills. So we're talking about novice training here, fundamental skills that are required to perform these procedural tasks. So when they come to the operating room, they're not so much focused on getting the instrument to the liver bed. They can focus more on what they're learning in terms of judgment and anatomy and the flow of the procedure. So I think that's sort of the goal in using simulation training. And there's, so in summary, for part task training, we have 6 trials. The 3 that I described, this one that I just described, and two other trials, very similar. And they all have different platforms, different curricula, different evaluations, and there are a lot of differences between them, but none of them they all show some benefit in the group that received training through simulation. Now moving to procedural simulation, there are three trials that I identified looking at procedural simulation. One was hernia, TEP hernia, one was gallbladder, and one was salpingectomy. The hernia trial is from 2001, so here's one of our speakers. As you'll see, there's a lot of people that you know. This randomized 21 PGY 3-4s. Half of them practiced mesh fixation in a simulator. And the outcome, again, was performance using a global rating scale. And again, there was some benefit to the group if we just look at the composite score for the group that received simulator training through blinded assessment had higher performance compared to the controls. The second trial, procedural trial, is from Sweden. In this trial, 13 residents were randomized either to using this virtual reality simulation, basic drills to proficiency, and then the dissection module. The dissection module, they did not have proficiency levels. They practiced in several sessions over a week, and the primary outcome was they combined the 1st, the 5th, and the 10th lap chole. So this was a nice way to look a little bit at more than just one case or the first case. It's a little more involved. Video review using the errors that like in Neil Seymour's paper by 2 blinded observers. And the results for the errors of the entire procedure, you can see far less errors were made by this simulation trained group. And again, and also the variability in performance was much tighter in the simulation trained group. This provides evidence for the development of expertise. One thing I didn't really understand was when you look at the differences in the 1st, the 5th, and the 10th operation is why the control group wasn't getting any better, which is a little bit of a concern. Finally, this is a really terrific study. I know Theodore was an author on this paper. I think this is really shows the evolution of this evidence. This is a really, really fantastic paper. 24 PGY 1-2 Obgyn residents randomized to, again, a virtual reality simulator with basic drills and practicing a right salpingectomy to expert proficiency. This took 7 hours, similar to what we found in FLS training, totally different curriculum. It's funny how it's the exact same number. And their primary outcome, again, was a previously validated scale from video by 2 blinded observers. And they found significantly better performance in the simulator trained group. They also described a cutoff points where they determined a competency level, and this was the first salpingectomy in clinical that they had performed, and 82% had reached that point, whereas 0 in the control group reached that point, and also it took them half as long to do the procedure compared to the control group. So that's a very nice study. And so the 3 procedural training trials also showed better performance for the simulator-trained group. So in summary, the question was, does simulation training improve clinical laparoscopic operative performance? Reviewed the evidence, and in all studies, the simulator-trained subjects had better performance than the non-trained controls. So in conclusion, I think skills acquired by simulation training seem transferable to the operative setting. As I mentioned, this is an evolving evidence base. There's improvements in study design, but I'm not sure that we need to continue with this ad infinity with each new simulation and each new platform that we have. And I'll just leave you with a quote from David Gaba, one of the fathers of anesthesia simulation, who wrote that no industry in which human lives depend on the skilled performance of responsible operators has waited for unequivocal proof of the benefit of simulation before embracing it. And I think that obviously we're certainly many people have come to that conclusion, and I think that the remainder of this session will show people what the next phase is in terms of introducing this technology in training.